So hi, everyone. My name is A10 Smail, and like it was just mentioned, I'm a PhD candidate in the Department of Mental Health at Johns Hopkins. And today I'll be talking to you about a recent project titled The Health Belief Model and Prevention Behavior During the COVID-19 Pandemic. Okay. So now at this point, we're all pretty familiar with the pandemic, but just to give some context to the paper, I'll briefly review the background and motivation for this project. So first, we know that throughout the proliferation of the virus, several prevention behaviors have been recommended by top health organizations, like social distancing, washing your hands, and wearing a face mask. Experts estimate that we could substantially reduce the spread of coronavirus if all people in the US adhered to these recommendations, but compliance with these recommendations is inconsistent. Patterns of adoption of these prevention behaviors have been associated with things like health beliefs, health literacy, and political affiliation. So we think that further exploration of these demographic characteristics and health beliefs could lead to a better understanding of how people are engaging in recommended behaviors and how these can be used for targeted programming. The Health Belief Model, or HBM, as presented on the slide, is a useful framework for considering factors associated with the likelihood of COVID-related prevention behaviors. It's built on the premise that people engage in preventive behaviors based on perceived threat and motivation to take action. On the slide, I've listed a few examples of how COVID-19 health beliefs can be contextualized in this model. For example, in this context, perceived susceptibility is how bad one believes it would be to have COVID, what would be the health and financial consequences of getting infected. The model suggests that the likelihood of compliance with recommended behaviors increases with perceived threat, provided that people believe that the behavior is effective and don't see any major barriers to engaging in the behavior like cost or inconvenience. The validity of these variables in predicting behavioral change varies, but most studies have found that perceived benefits and barriers, which are now highlighted in green, are the strongest predictors, whereas perceived threat and severity, which I've highlighted in red, are generally a bit weaker. Still, we think that this model is particularly useful for simple behaviors like mask wearing and hand washing. So in this study, we apply HBM to describe patterns of COVID-related prevention behaviors in the US. The objectives of the study are to characterize patterns of prevention behaviors during the COVID pandemic 3 months after it was declared a national emergency, to identify differences in prevention behaviors by demographic characteristics, and to determine how those patterns are associated with health beliefs like perceptions about susceptibility, severity, and effectiveness of recommended behaviors. Data for this study come from the UAS. I won't describe it in detail since we already heard about it during our welcome message, but I will mention that the current analyses use data from 2 waves, UAS 230 administered March 10th through March 31st, and UAS 246 administered May 27th through June 23rd. So here I'll talk in a little bit more detail about the conceptual framework of the study. We were able to identify 3 health beliefs in the March data. Susceptibility, measured by a question that asks, on a scale of 0 to 100%, what is the chance that you will get infected with the coronavirus in the next 3 months? Severity, measured by a question that asks, if you do get the coronavirus, what is the % chance you will die from it? And effectiveness, measured by 3 questions that ask, on a 4-point scale, from extremely ineffective to extremely effective, how effective are the following actions for keeping you safe from the coronavirus? Perceived risk of infection and death were categorized into no risk, low risk, and high risk based on response distribution, and effectiveness was included as a continuous score ranging from 3 to 12. Latent class membership over on the right was assessed using data from the late May to late June wave, when most of the state and federal guidelines were relaxed and people were able to engage in prevention behaviors at will. The latent class analysis used 10 binary indicators to measure endorsement, including wearing a face mask and washing hands. A complete list will be available when we look at the results in a few slides. So I'd like to begin the presentation of results by showing you a snapshot of Table 1, which includes the demographic characteristics of the participants. Again, these estimates are survey weighted, so they reflect the distribution of some demographic characteristics of the US. As you can see, we have a good representation of individuals across the lifespan, with about 1/3 of participants in the largest age category of 60+. We have a roughly even split of males and females, and about 2/3 of the participants are white non-Hispanic. For the sake of time, I'll not show or describe the rest of Table 1, but please feel free to ask if you have other questions about the sample. So moving on to results, the class membership. as I mentioned before, 10 binary indicators were used to describe the patterns of latent class membership. These indicators are listed on the horizontal axis toward the bottom of the slide. Goodness of fit criteria revealed a 3-class model. And class 1, which you see represented by the solid black line, shows the highest pattern of engagement among classes in all prevention behaviors. Conversely, class 3, which you see represented by the dotted gray line, shows the lowest pattern of engagement in all prevention behaviors. Class 2, which I've labeled the mixed engagement class, follows a unique pattern of engagement. For the first 7 behaviors, they look more like the high engagement class, whereas for the last 3, they look more like the low engagement class. Upon examination, it appears that they follow most prevention behaviors except for the social ones, such as working from home and canceling work and social activities. So now we'll transition to looking at the correlates of class membership. I'll begin by presenting the demographic correlates. As a caveat, all of the shown results are in unadjusted models to simplify the tables, but almost all of the correlates show the same associations in adjusted models. Another quick note, class 2, the mixed engagement class, is the comparison class in these multinomial logistic models. I'll begin by directing your attention to the age category. As you can see highlighted in red, the 2 oldest age groups, ages 50 to 59 and ages 60 plus, had significantly lower odds than the reference group of being in the low engagement class relative to the mixed engagement class. Individuals aged 60 and up were also less likely to be in the high engagement class. If we take a look at sex, males had a higher odds of being in the low engagement class, though this was not statistically significant, and significantly higher odds of being in the high engagement class. I'll let you skim the rest of the results yourself, but in general, all racial ethnic groups had a higher odds of being in the high engagement group, and those with higher education levels were also more likely to be in high engagement groups. Now moving to health beliefs. As you can see on the slide, all health beliefs were significantly associated with class membership. In the top left corner, we see that the odds of being in the low engagement class relative to mixed engagement were significantly lower for both those in the low risk and high risk categories relative to no risk. Similarly, the odds of being in the high engagement class on the right were significantly lower for the low risk group relative to the no risk group. The other health beliefs, perceived risk of death and effectiveness of CDC recommendations, were also associated with lower odds of class membership, but only for the low engagement class relative to the mixed engagement class. So to conclude this presentation, I'd like to restate that this nationally representative dataset highlighted 3 latent classes of prevention behaviors in late May to late June, at a time where most state and federal mandates were lifted and individuals were no longer required to engage in prevention behaviors. The health belief model was used as a framework to identify health beliefs in the data that were found to be associated with the odds of class membership. These findings highlight the potential utility of using the health belief model to inform health communication campaigns and other prevention efforts to reduce the spread of COVID-19 and future pandemics. Thank you for your attention during the presentation, and I'll just take a quick moment to acknowledge my co-authors over there on the left and the mental health working group at Hopkins over on the right that has provided some mentorship throughout my COVID-related research. Thank you.